All right, and welcome back to the STMCA podcast. I'm Craig Thomas, I'm MD3,
And I'm David Cromp. I'm MD2.
and this podcast's topic is sea collars. And David, I know that you've spoken a couple times on sea collars, and it's a semi controversial topic, but I think there are some nuances where we definitely do need to be using them, and I'm hoping you can shed some light on that.
Yes. And I do want to preface this podcast with the fact that all three, both the American College of Surgeons, ACEP, which is Emergency Physicians Governing Body, and NAEMSP have all made a joint statement saying that spinal mobility restriction, such as what we use C collars for, it should be applied in any case where there's altered mental status and blunt trauma, as well as the other stuff that we know it for: spinal deformity, numbness, paresthesias, neurologic deficits, and trauma, any injury where you're concerned about a spinal fracture or deformity and stuff. So at this point, we're kind of aware of what we use the C collars for, but the question then becomes, how do they work? How well do they work? And what are the alternatives? So technically speaking, there are no alternatives. The C collar is the standard of care. But we've all been in that situation in the field or in the ER where you have the drunk patient who hit their head, or had somebody run into their leg and broke a femur or a tibia, and you're having all this trouble getting them to wear this collar when they don't have any injury in the neck. Cervical collars, a lot of studies have been done, and it shows that they don't restrict mobility as well as we would like to, and that a large portion of the time they're not applied correctly. And that's not a stab at us as providers. It's just saying that there's a lot of people with a body habitus or a neck type that C collars don't do what they're intended to do for. So one of the things that a C collar is meant to do is it's meant to get under the chin. It's meant to secure the posterior aspect of the neck and kind of extend, not necessarily extend the neck, but distract or extend the vertebrae and put it into this neutral alignment, so that not only can the patient not turn their head or rotate their head left or right, but that they also can't extend or flex the cervical spine. And the thought process behind this is that anywhere from 5 to 25% of spinal cord injuries come with an associated second injury. And it's just not possible to tell when a patient is altered because they won't clear the Canadian C-spine rule, they won't clear nexus criteria, that there's not a cervical spine injury. And we have had minor traumas that result in small cervical spine fractures. So to play it safe, a cervical collar is your best bet. Several of our staff know that when a patient absolutely won't wear this hard collar, they can transition to something else, either a towel, which really is more of a reminder to say don't move your neck, as it doesn't really provide any limitation. But there are some good studies coming out on soft cervical collars, which are more comfortable but still provide a degree of distraction and still kind of prevent extension and flexion. Obviously, these collars don't work if you've got a patient who won't listen to you, but you've got an elderly 80-year-old who fell and maybe bumped their head, and you want to put them in a collar, but they have too small of a neck or too big of a neck to fit into a hard collar, a soft collar. I don't want to say is a reasonable alternative, but there's some studies that suggest that it may be. Again, when it comes to C collars, we have to put them on because these are the guidelines that we are meant to follow from multiple bodies regarding emergency medicine and trauma.
And speaking of guidelines, if anybody has any questions, we actually have it all laid out on the STMCA website, specifically what our protocols are. And I know one of the major things that we've been seeing a lot of is age-related cervical collar placement that we
Yes.
need to be concerned about. So you want to talk about age and cervical collar placements a little bit?
Yeah, so obviously the older that a patient gets, the less adipose tissue they have, which means there's a lot more hard tissue on hard parts of cervical collars. So when it comes to this, you run a little more risk that the higher up we go in age, the higher the risk of ulcer formation, discomfort, and even inappropriate placement of the collars. Nexus criteria doesn't include age necessarily, but C-spine criteria, Canadian C-spine, includes an age of 65. So a lot of protocols that you see tend to say you have to place spinal precautions in a patient with a blunt trauma over the age of 65. And you're pulling up our stuff right now, and we actually have an age of 65 as well. The biggest thing is noting that if there's a potential for injury, especially if you have to extract or move the patient, that a rigid collar really is appropriate. So there's talks about this all over the country at trauma symposiums. It's one of the things that may change in the future, but as of right now, 65 or older, C-collar is appropriate, and do your best to put it on. I know you guys always do. Um, but there is some literature to keep an eye on in regards to their efficacy. I think it's kind of the same kind of thing we saw with backboards back when those were used for everyone. They still have their uses. They're still applicable in certain situations. But this is more of a developing literature kind of scenario.
Yeah, I think
And
there's definitely some nuance out there, but like you said, if there's a concern for a spinal cord injury, the patient's over 65, they're altered, there's intoxicants on board, there's a distracting injury like an extremity injury, or if you have any motor or sensory deficits, you need to be placing that C collar. But definitely something to keep an eye on.
yep. And if you have any questions, as always, we're available. Let us know, and we'll see you on the next podcast.